any approaches to treatment? Any sort of thoughts on where we might go to help these people?
Oh, well, I think that in the first instance, many of them will have a medication overuse problem because they'll develop this. They'll just go along to the shop and they'll buy things, and by the time they come along, they'll be taking quite a lot of medicine off their own bat, and it can be very often really quite helpful to count that up, get that sorted out, control that problem first, and for a degree of them, the medication overuse has become the problem, and you resolve it that way, and then put that down. The other side of it is to try and phenotype the headache, as we were talking about before. What are the features, and treat the underlying type of headache that gets turned on, because effectively you can see tension type headache and migraine and cluster headache all turned on from trauma. That's why I think it's you bring the genes to the party and then something happens, and the only practical treatment we have at the moment is to diagnose this underlying thing that you bought, or type of headache, and treat that.
Okay. So I guess for most of them, amitriptyline sounds like it's coming back into the
yeah,
spotlight.
That's right.
Yeah. Okay, thank you. I'd like to look now at exercise-induced headache. First of all, the sex headache, that's a well-recognised phenomenon. There's two types of sex headache, the pre-orgasmic and the orgasmic. Could you just say a little bit about each? In particular, which one do you think we should investigate, if either?
Yes, you say the two types of headache. There's the one that builds up slowly with sexual excitement, and then there's a sudden onset orgasmic headache. The one that needs investigation is the orgasmic headache, because it's indistinguishable from subarachnoid. Now, so it needs, on its first presentation, it needs investigation in its own, of that merit, that is a sudden onset headache, in the way we were talking about in one of the earlier tapes. So I think that's clear. The build-up headache, I think that if that's got a normal examination, it doesn't need investigation, because it's absolutely typical of what it is.
I read somewhere, I don't know if it's right, there's never been a secondary cause demonstrated for a build-up headache. I don't know if that is correct or not, but you wouldn't investigate anything?
I wouldn't investigate. No. Normal examination, pre-orgasmic, I wouldn't investigate.
Okay. Someone who comes in, they very rarely come in with their first one. They might come in and say, for the last 6 months I've been having orgasm. What do you do then? Well,
you're between a rock and a hard place, because you could say to them, well, you've had this a number of times, so the chances you're going to bleed is very small. However, that's not going to play very well if that happens to be the one, in several hundred that actually have the problem. I think that sort of person who comes and says that to you, he's got you sort of stuck in a position where you need to get them investigated. And that probably means referral, because they're going to need imaging of their vessels. It's very hard not to do that. If someone like that's sent along to me, then they're going to get an MRA, because because it is impossible to distinguish the phenotype of orgasmic headache from subarachnoid hemorrhage. I'm not prepared to take the chance, just because a person's had several of them, that you mightn't be this might be the one who's going to die the next time they do it. So I think they need investigating, and if it's in the purvey of the GP to be able to arrange the MRA, why not? It's a logical thing to do if there's logic to it, and if they can't, they're going to have to refer. But I think that needs investigation.
Okay. Well, I wonder if I could pick up on this. We're going to be talking about investigation in the next tape, but this difference between MRI and MRA. You think if you're anticipating a vascular problem, then they should all have an MRA. It's far more sensitive for vascular.
Well,
would an MRI pick up a problem?
In the person we're talking about who's got sudden onset orgasmic headache, they're going to need an MRA to explicitly look at the vessels to exclude, as far as is reasonably possible with an MRA, an aneurysm. So they're going to need that. It's reasonable, I think, to get an MRI at the same time, because it doesn't add much to the sitting. But it would not be sensible to do an MRI and not image the vessels in someone who had an orgasmic headache presentation.
Right. So the MRA is much more sensitive to small aneurysms than the MRI?
Yes.
Yeah. Okay. And what about treatment? Treatment options for both types? Well, mainly you'd be treating the pre-orgasmic headache, I guess, wouldn't you? But some people do have quite frequent orgasmic headache. What would your treatment armamentarium be?
Now, the best treatment for orgasmic headache excluding the obvious one, which is to avoid it, which is hardly acceptable for most people. The best treatment is indomethacin, given 25 or 50 milligrams, given about half an hour to an hour before sexual activity, is usually really very good at stopping it coming altogether. If frequency or side effects makes that not practical, then the best established of the preventive treatments are beta blockers, but typically propranolol 40 to 80 milligrams twice a day would be that sort of range of treatment.
One of the side effects of beta blockers, of course, is impotence. So, we're all a bit concerned in GP land about using beta blockers. But I guess
yes, it seems like a rather circular discussion, doesn't it, to induce impotence as a way of stopping orgasmic headache. But the impotence is not 100%. It's not a 100% thing. I mean, I think that we're always having a sensible discussion with our patients, aren't we, about here's the problem, this can be helpful, you have a small chance of getting this side effect. So, are we going to sit and watch, or are we going to do something?
Yeah, okay. I mean, very much aligned to sex headache is exercise-induced headache.
Yes.
Well, I guess pre-orgasmic headache may be a type of exercise-induced headache. Do you think it's similar, or do you think it's something different? Do they get exercise-induced headache, or is it just with sex?
Yeah, it's a remarkable thing that most people I've seen with exertional exercise headache don't get sex headache, no matter how healthful ever they are involved in their sexual activity. And vice versa, the sexual activity headache people don't tend to get exertional headache. So while there are some interesting similarities, and these differences are not explained at all, I think they're quite distinct.
Yeah. Okay, if you could just pick up on exercise headache, obviously a primary headache can get precipitated by exercise. It's not uncommon for migraineurs to get a migraine attack when they exert themselves. But we are concerned about secondary exercise headache. Is this an underlying space-occupying lesion here? And I guess anyone that presents with exercise headache should be imaged.
Yes, I think that's a fair comment.
Even if it's been around for some time.
The problem is, when's the first time that they're going to come along, and what are you looking for, and could it have a natural history? And the answer will be yes, it could have a natural history. So I think it's, we could draw a scenario and ask me whether if a person had 50 years of headache, would I still image them? And I'd wonder, but I guess I'd do it out of curiosity. But in reality, most people don't turn up with a history of 50 years of exertional headache. So exertional headache is sufficiently unusual to warrant imaging, and I think that it's fair. If we imaged all the patients with exertional headache and none of the patients who were just getting imaged because they were worried, I don't think the NHS would go broke.
And the treatment very similar for sex headache, indomethacin and beta blockers, similar sort of treatment.
That's right.
The other thing that's related in a similar way really is this raised pressure headache with sportsmen weightlifters. This due to increased venous pressure. I guess exercise headache is more related to increasing cardiac output.
Yes.
Some sports and some exercises will increase your venous pressure. You can get a headache, typical Valsalva headache.
Little trap we should have talked about with exertional headache, I suppose, is this cardiac cephalgia problem.
Very rare, though, I guess.
Oh, yeah, very rare. But no one thanks you for the
Have you
things
seen one?
like
Have you ever
that.
seen that?
Yeah, I have. Interesting, an interesting problem. So cardiac cephalgia, where the patient is exercising and gets head pain, and when they stop exercising it goes away, and when they start it happens again, and it turns out to be a myocardial ischemia presenting with referred pain to the head. And it's the tight link between the exercise and the head pain which starts you off thinking about it. So I know I shouldn't be mentioning the too rare of birds, but I think the rare things that have implication are on the table.
Yeah. And this raised venous pressure of Valsalva headache, we were worried there again about this Arnold-Chiari malformation. Can you say a little bit about that?
Yes. So Arnold-Chiari malformation is sagging of the back part of the brain, the cerebellar tonsils, coming down into the foramen magnum and compressing the brain stem. Can present as cough or Valsalva maneuver headache, and because we think it's because the brain's being pushed down. Very often there will be some associated symptoms with that, or associated signs, so some disorder of eye movements or unsteadiness, some dysmetria, intention, tremor, cerebellar signs. Those, again, the difficulty with cough of Valsalva maneuver headache is that the primary and the secondary version are indistinguishable, and one's committed to imaging them.
And you might find a descent, and that might not be the cause of the problem, I guess, as well. So before you know where you are, you're in front of a neurosurgeon who's quite keen to operate, and it's not always the right way forward. Is that right? Or
I think that's absolutely right. I think that that if you find a patient who's got a Chiari malformation, it's worthwhile thinking through the headache problem first. An example of this is the low pressure headaches we were talking about in the last tape. With low CSF volume headache, you can also get a Chiari malformation because of the low pressure that normalises when you normalise the pressure. But if you go around taking bits of the bone out at the back, then that's very unhelpful.
Okay. Peter, there's a lot of other secondary headaches we could talk about. I just want to pick up one or two in this section. First of all, headaches that occur around sleep. Headaches in the morning. I think we see a lot of patients with obstructive sleep apnea. There's this thing, hypnic headache. Can you say a little bit about headache around sleep?
Yep, there's some important conditions. I think that an important one you've hit on is obstructive sleep apnea. Typically produces headache when the person wakes up, an early morning headache that gets better during the day, and you know the body habit is better than I do. So that's one to be a real flag. You see other things that happen. We've noticed a number of cases over the years of hypertension, turning to a subject, presenting with headache that's particularly nocturnal. So a person awoken from sleep with a troublesome but otherwise featureless headache, and think about blood pressure as a problem. And then hypnic headache, you mentioned, is headache that's produced going to sleep. So a patient goes to sleep well, they typically wake up an hour and a half into sleep with a bilateral or unilateral, largely featureless headache, lasts for about half an hour to an hour, they go back to sleep, and the unlucky ones get woken again in about 2 hours, and the same thing happens. Featureless tends to be bilateral. The differential diagnosis is cluster headache, and other things we'll be talking about at another time. Very rare condition, that condition.
I guess obstructive sleep apnea is the most common problem
Yes.
for GPs. Raised CO2 triggers off underlying migraine, vasodilation. What's actually happening here?
Well, raised CO2, change in pH. I can invoke anything that I want to in the brain or not, and I think that if you've got migrainous biology and you alter the pH of the entire body, you might expect to have headache as a result of that. I think that's probably a common basis for it. And changing pH has such a myriad of effects.
So it could be a lot of things.
A lot of things, yeah.
Before we move on, I just wonder if you could pick up on pain from other facial structures. I mean, I just wonder in your clinic how many people do you see that have come in with headache but in fact have facial pain somewhere? Do you see a lot of those people?
Well, it's well recognised to have that migraine can be referred to the face. People used to call it facial migraine. I don't think that adds anything to it, because clearly the referral is usually first division, but could be second and rarely third division.
But headache originating in the face, the other way around I'm talking about now, that causes facial pain, sinusitis,
I see
glaucoma.
what you mean.
Do you see many facial causes manifesting as headache presentations?
I think they tend to go to other people. I think the ENT people see that. I see facial pains largely after dentists have overdone it, so to speak. So people who've had multiple nerve root treatments who end up with neuropathies, that sort of thing is the big area where we'd pick up on facial pain syndrome.
I think certainly sinusitis is something. I see a lot of GPs who make the diagnosis of sinusitis, which is in fact migraine. In fact, there's a paper published not so long ago that looked at a series of sinusitis, 85% of which was migraine, which was quite interesting. So I think you need to be very, very wary when you make a diagnosis of recurrent sinusitis. And I guess a lot of these people have had their sinuses drilled out and all sorts of things.